Welcome everyone to BayCare Presents. I am very excited to have Dr. Khalil here with us today. He is a cardio-electrophysiologist with BayCare Medical Group, and he specializes in the diagnosis and treatment of heart rhythms and giving a comprehensive look at different conditions such as atrial fib, which we're going to be talking about today, and other complex arrhythmias. So he is committed to evidence-based compassionate care, and we are very lucky to have him here today to share his expertise. So I am going to turn it over to you and let you start sharing. So thank you.
Very good. Thank you so much, Ms. Jean-Marie. Good day, everyone. I'm Charl Khalil, as Jean-Marie just said. I'm a cardiac electrophysiologist, so we specialize in abnormal heart rhythms, and it's a subspecialty within the cardiology field. And I was approached to briefly have a nice conversation and talk with you today about atrial fibrillation, abnormal heart rhythms in general, and atrial fibrillation, which is the most common abnormal heart rhythm that people experience nowadays. It's very important to learn about the basics of AFib, what that could be, and the implications and the consequences of getting this under control. We'll make it quick and easy and fast. I know everyone's probably on a lunch break. So a few things we're going to talk about today. What is the normal conduction of the heart? How does our heart beat regularly in sync? And what is atrial fibrillation? What are the stages of AFib? Why does it even matter for any of us to know about AFib? And then what are the symptoms? What are the concerning things that I should be alarmed when I see or when I feel? What are the risk factors, and how do we diagnose AFib? Treatment options that we have nowadays. Watchman procedure. I'm going to talk about this just because there are so many ads everywhere, and I get a lot of patients asking us almost on a daily basis about the Watchman procedure. What can we do to reduce the burden and prevent the recurrence? What can I do as a patient or someone who experiences AFib to help with management? So just very important to know that one of the very fascinating things about the heart that it really works in harmony. It's everything happens in the heart in milliseconds, and within the clinical cardiac electrophysiology world, we never talk in seconds. We speak in milliseconds, and this is true because the everything happens in the heart is very, very precise. So our hearts beat in sync, and I want you to think about it as an orchestra, and there is one maestro that helps with orchestrating this whole heart rhythm thing, and helps our heart beat in a very regular and organized fashion. So the normal conduction system of the heart. So we all know that we have 4 rooms in the heart, right? 2 upper rooms, 2 lower rooms. What we really care about the most are the lower rooms, simply because those are the rooms that push the blood to the rest of the body organ. So the right lower room pushes the blood to the lung to get oxygen, and then the left lower room is the one that actually pushes the blood to the rest of the body organs. The 2 upper rooms, which we call atria, act as reservoirs. So it's just more of a place for the blood to pool before the lower room is ready to receive the blood. And then when it's ready, blood follows from the upper room to the lower room, which we call ventricles. And then the lower room pushes the blood to the rest of the body organs. Now, it's very important that the lower room takes its time to fill with blood. So it relaxes, fills with blood, squeezes, pushes the blood forward, relaxes, fills with blood, squeezes, pushes the blood forward. And this happens in a very organized fashion. And it happens if the lower room is beating at a certain rate. Faster is not good, lower is not good. So how does our heart know that, okay, beat at 60 beats per minute now? So the maestro that we're talking about is called the sinus node. And I'm going to go back just one slide here. It's right here. It's this, what we call the pacemaker of the heart. This spot in the right upper room is the spot that kind of orchestrates everything in the heart. So it sends a message. That message flows, goes down to a link or a connection between the upper room and the lower room. It's a guard, and that guard allows the message to go down so the lower rooms can contract. Now, this pacer or this maestro, which the medical terminology is sinus node, it it gets influenced by a few things. If I'm relaxing, sitting down, just not doing much, 60 to 80 or 90 beats per minute would be fine. So it will send 60, 70 messages that will travel, go to the guard, and then from this guard will go down so the lower chamber can contract and squeeze. Now, if I get excited, we're running, we're angry, we're happy, we need more blood flow in our body organs. So now we have to get more blood supply. The heart beats at 120, 140 beats per minute. And that's when this sinus node starts sending more messages every minute. Same course, same system, conduction system or wiring system, and then the lower chambers beat. So as you can see here, it's just the sinus node lights up first, and then this goes through wires to the guard, and from the guard goes down to the lower chambers. Very organized, all happens in sync, one thing after the other. Now, what is atrial fibrillation? So atrial fibrillation is when the top chambers of the heart start quivering instead of beating regularly. And why would this happen? We said that there's only one master in the heart that sends the messages to the rest of the heart to start beating. Now, every now and then, in the left upper chamber, we get some bad guys, different spots that will say, we're the masters, we're the maestros, we're going to give the heart instructions to start beating. And then the upper chamber gets confused, receives so many messages, and that's when it starts quivering. So this is normal conduction, heart beats in sync, sinus node. No, back, I'm gonna go back a second here. Sinus node, again, sends the message, it goes down the yellow routes or the wiring system to the guard that takes it to the lower chamber. As you can see on the upper EKG strip, it looks very organized, regular. Now, if it flips into atrial fibrillation here, you see how this becomes very irregular, beats so fast, and instead of having one master in the upper chamber, you have multiple foci or multiple spots that are sending electrical impulses for the heart to start beating in an abnormal fashion. Now, this becomes a problem for many reasons, and I will quickly say why would that be a problem. But just to understand what's atrial fibrillation, is simply instead of having one focus in the upper chamber, giving instructions for the heart to beat, now you have hundreds of those, and the upper chamber starts quivering. And then this guard that's used to receiving 60, 70 messages from the upper room to pass those messages to the lower room, it's now receiving hundreds of those messages. And it starts getting confused. Okay, what should I allow to pass to the lower chamber versus not? This AV node is a guard, and the whole point is to prevent this very fast heart rate in the upper chamber from going to the lower chamber. It looks up and it goes, okay, 60 beats per minute. I'm okay with that. Let's let those go to the lower chamber. If it sees 150 beats per minute, it gets really confused. No, I don't want this. We're only letting half of those go to the lower chamber. It's a very important protective mechanism that we all have to prevent the lower chambers from going crazy. Now, someone gets AFib. So what are the stages of AFib? In the beginning, someone might get 2 or 3 minutes of AFib just a day, like intermittent. We call this paroxysmal, where the heart is mostly in sync. Sinus, the normal maestro is doing its job. And then maybe every now and then you get, 2 or 3 minutes of abnormal electrical activity in the upper chamber, AFib. And we call this paroxysmal, just intermittent. As we leave it, those 2 minutes become 2 hours. The 2 hours become 6 hours. The 6 hours become 12 hours. The 12 hours become 24 hours, and it gets longer. Once it starts crossing the 7-day mark, we call it persistent. So if someone stays in abnormal heart rhythm for almost 7 days, that's when we call it persistent AFib. You leave it for 1 year straight, call it long-standing persistent. Longer than that, we call it permanent. So it's a very, it usually starts in a very subtle way. And as we leave it, as it's not addressed, it gets more and more progressive and eventually becomes longer and stays for longer periods of time. Now, what is the prevalence? Why are we talking about this now? And this is actually the shocking part. A lot of time I get patients in the clinic who think that probably they're the only one who has AFib, but then I'm going to tell you a little bit about the data and how many human beings on Earth and in the United States of America who have atrial fibrillation. As of like this 24-25 data, 2024-2025, we have almost 10.5 million US adults who have AFib. Projections of 12 million people by 2030 will have atrial fibrillation. And it's very known that with, I hate using the word aging, as we get wise, the incidence and the prevalence kind of start going up, and the risk of developing AFib becomes much higher. The tricky part about atrial fibrillation, which I'm going to talk about, is a lot of people do not feel anything while they're in AFib, and that's the problem. Some people feel, and almost 60% of people who initially, especially in the early phases where it's paroxysmal, your heart goes in and out, you get just very subtle symptoms, or you don't get anything. Now, this is also important. The overall lifetime risk for someone to develop atrial fibrillation is almost 30 to 40%. And this is for people above the age of 40. And as we even, grow older, the risk becomes higher. So I want you to imagine that all of us, every 10 human beings, 3 or 4 will develop atrial fibrillation at one point in their lives. And the recent data is even saying above the age of 80, almost 50% of people will develop atrial fibrillation. So it's extremely common. A lot of people do not realize it. When patients show up in my clinic, freaking out, so I have AFib, I always calm them down as like, this is almost every 10 human beings, 3 or 4 will experience AFib at one point of their lives. Now, why is it important to know about, okay, so what? I have AFib, I'm not feeling it. What can happen, right? Anytime our blood does not flow in a very smooth, nice pattern, there is a risk of clot formation. So if the upper chamber starts quivering, blood can pool, become stagnant, and then clot forms. And if clot forms on the left side of the heart, which is the most common area for blood clots to form in atrial fibrillation, they can break into pieces, goes the blood flow, and then it goes up to the brain and it causes a stroke. And I cannot stress enough on how many times I've seen, unfortunately, patients showing up with strokes at the hospital that were never diagnosed with atrial fibrillation before. And that's the most dangerous thing about AFib. I mean, there are a lot of things that we're going to briefly just touch on and talk about today, but having a stroke is a devastating outcome. So abnormal heart rhythm, clot formation in the heart, this clot breaks into small pieces, goes with the blood flow. Of course, it can go to different spots. It goes to the eye. It can cause visual issues. And if it goes to the legs, you will have issues moving around. If it goes to the brain, it's a stroke. So that's a very, very important thing to know and understand about atrial fibrillation. And it's important, we'll talk about this later. The risk of developing a stroke from AFib is also affected by multiple other things. If you have AFib and you're 50 years old, is different than having AFib at the age of 17. Is different than someone who is 70 years old and has diabetes and hypertension. Okay, what else? I mean, so stroke is unpleasant. What else can we have? What we call congestive heart failure. So what happens here is by time, and as we leave AFib, just as we stay longer periods of time with AFib, our heart muscle becomes weaker. Every squeeze becomes weaker. And as this, it continues to progress, it gets worse and worse. And then we develop what we call heart failure. So as you see on the left-hand side, you see how thick the muscle is. This is a good functioning, strong heart. And then by time, you see on the right-hand side, the walls become thin. The chamber itself, the room itself becomes bigger and larger, and this is not good. It's dilated. And that's when we start having issues with fluid buildup in our lungs, develop heart failure. You get into you're not being able to push blood forward in an appropriate way, and you start getting a lot of symptoms. So another important thing, by us not treating AFib and leaving AFib take its course, is developing heart failure. Now, what are the symptoms? Okay, how do I know that I might have AFib? I mean, we mentioned that there are people who are not feeling anything, and that's kind of tricky. And there are things that we can do to detect AFib. But How would people know that they're having AFib or at least an abnormal heart rhythm? The one thing I didn't mention in the beginning is AFib is the most common arrhythmia that we have, or abnormal heart rhythm, but there are other ones too. Anyways, whenever you're having an abnormal heart rhythm, what are the symptoms? Palpitations is number one. All the time. I get patients who would tell me, hey, I'll be sitting, all of a sudden I feel my heart is fluttering, or my heart is racing, or my chest is pounding. Something is off. And this could last for a few seconds, could be minutes, could be even longer. So palpitations is important. If your heart goes too fast, that there is not enough time for the lower chamber to relax and fill with blood and squeeze the blood and push it forward, there's not enough blood going to the brain, you get dizzy, or you can even pass out. So dizziness that comes out of nowhere, all of a sudden can last for a few minutes and then resolves. That's very concerning. It's an alarming sign. Or passing out. Of course, if AFib get very fast heartbeats, it lingers. It can cause patients to have complete syncope, like they just completely pass out. Another thing is, again, every time your heart is not beating at a good rate and it's not pushing the blood forward, you get fluid buildup in your lungs and you feel short of breath. So palpitations, dizziness episodes, I'm having shortness of breath. Chest pain, yes, absolutely. I mean, you have some tightness in your chest. You feel that you're having a pressure sensation, or you're having some sharp pains. That could be also from atrial fibrillation. If you're feeling fatigued and tired, and you're short of breath, and you start getting sweaty out of nowhere too, that's concerning. And of course, if this lasts for longer periods of time, you feel that you don't have enough energy, you're tired, and you're fatigued. So those are some of the symptoms that are kind of alarming, and a lot of times it would kind of warrant investigation, so we can do a few more things to kind of detect AFib or whether we have AFib or not. As I mentioned, this is the biggest risk of the biggest problem. One of the biggest problems of atrial fibrillation is having a stroke. And unfortunately, I mean, I can tell you that this happened even less than 2 weeks ago. A young gentleman who was never diagnosed with AFib came to the ER with stroke, and by looking at his EKGs and everything else, we realized that he had AFib. So, it can really alter your life all of a sudden. I don't want to scare everyone, but it's important to be aware where things are fine, and then God forbid you have an abnormal heart rhythm, clot is forming. This clot dislodges, goes to the brain, and you develop a stroke. So this is an MRI that shows this bright spot. This is a stroke that was seen on brain imaging for a patient before. Now, since we're talking about it, this is kind of not really what we're discussing today, but it's important to just go over this quickly. I'm sitting at home. I have a family member around, or a friend, or a grandparent, or someone who starts showing some facial asymmetry. There is a facial droop around the mouth, or the eyes, or the wrinkles are different from one side to another. That's concerning. Okay, that could be a stroke. And arm weakness, of course, any sudden onset weakness in any of the body parts, where all of a sudden someone is not moving his arm or not being able to move his leg, that's concerning. Very common, especially with as people age, you get speech difficulty. Someone is sitting, trying to talk, trying to say something, they cannot express themselves. That can last for a few minutes, or can linger and stay longer. That's also concerning sign. And then if you have really bad headaches that come out of nowhere with blurriness of vision. So we call this kind of the FAST, abbreviation. But just be aware that, because you can actually save someone. If someone starts developing any sudden onset strange neurological symptoms, a lot of times this will mandate 911 call, take them to the ER, because even if stroke happens, we have a 4-hour window to reverse it or try to fix it. And then there are different ways of trying to deal with strokes. The earlier, the better. Now, what are the risk factors for atrial fibrillation? I was just talking to a patient in the clinic like 2 hours ago. New diagnosis was AFib, and he's like, "What did I do wrong?" To be clear and honest, sometimes it just happens, and it has to do with genetics. But there are other factors that really play a big role into this. The most important, there are a few ones that are very common. Coronary artery disease. When I have blockage in one of the arteries supplying the heart, I get a heart attack that damages part of the heart muscle, and that can cause alteration in how our electrical system works. Number two, obesity. A lot of weight gain, a lot of obesity is found to be an independent risk factors for one of the risk factors for AFib. Sleep apnea. And I would say sleep apnea again, just because a lot of people don't know how serious sleep apnea could be. Sleep apnea, when it's not treated, when people are not okay using their CPAP at night, it really causes a lot of issues, including increased pressures inside the heart, and it can cause what we call dilation in the chambers. One of the upper chambers can even be a little bigger, and that can provoke atrial fibrillation. High blood pressure, diabetes, and of course, increased alcohol consumption. A lot of drinking can cause your heart to be provoked. Data on caffeine as well. But when I say caffeine here, I'm not talking about 1 or 2 cups of coffee. I'm talking about 5, 6, 7 cups of coffee and energy drinks every day that can provoke the heart and put you into AFib as well. How can we diagnose AFib? There are a few things that we can do in the outpatient world or like on day-to-day basis if I'm concerned or I feel that I'm having symptoms. And there are things that a physician can only do to detect atrial fibrillation. Just it's common sense. If I am in AFib frequently, it will be easier to detect, to diagnose. If I'm in AFib once every 2 weeks, 3 weeks, that's when it gets really tricky. So things that we can simply do, I have palpitations. I can always pulse check, 2 fingers, put it under your thumb and just on your wrist, and then try to see if your heart still beats in sync. Now, even while we're talking now, you should get used to how a normal heart rhythm feels, right? So just put your 2 fingers on your wrist and try to see if it's beating like a ticking clock. Now, if you're instead of boom, 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 you're getting abnormalities and things are changing fast, then that's concerning. A second thing, the gold standard is an EKG. If you're having an EKG in the ER or something while your heart is not beating in rhythm, that's AFib right away. Where we can catch it, that's that easy. But not everyone has. If you're in the ER for any reason and we have AFib, that's fine. We can diagnose it on an EKG, we'll be okay. But what if I'm at home? We're so grateful now. There's so many technologies out there, and I get patients all the time telling me that my Apple Watch or this smartwatch told me that I have AFib. They're not 100% accurate, but I would say at least 80% accurate. So if your Apple Watch all of a sudden notifies you that you're getting AFib and there's an abnormal heart rhythm, then it's an important thing to immediately seek attention. It's like, hey, what do I do about that? I love this app. Cardia is pretty much a small monitor, metal piece that connects with an application to your smartphone, iPhone or Android. And anytime you're having symptoms or you're questioning it, you put your fingers on this small piece and it gives you a strip on the application and it saves it as a PDF too. So your provider, your primary care, your cardiologist, your electrophysiologist can take a look at those later on and tell you if it's AFib or not. And they're very, I'd say, extremely accurate, actually. So I use Cardia app a lot. Patients who don't have the diagnosis of AFib and they have symptoms and they're questioning it, we use it. If a patient is even with a diagnosed AFib and we're trying to assess the burden, like how much or how long he stays in AFib, we can use those as well while we're trying to titrate medications and stuff. And now, of course, monitors. So if you come to the clinic, you tried the Cardia, we're not seeing anything, you're trying your Apple Watch, it's not notifying you, but you're still telling me I have palpitations and I'm not feeling well, then what we can do is we stick in the past. You can see the gentleman on the left side of the screen here has so many sticky patches. Those used to be, and we'll send them home with those patches. They walk around with it. It's kind of inconvenient, but with advancement of technology, there is no wiring now. It's just one sticky monitor that we put on the chest, and we give you a phone with it or an application, and it records all your heartbeats and can keep it on for up to 4 weeks, actually. Now, if it happens that you're having symptoms while you have the patch on or the monitor on, and there are different companies. There's ZU, there's Boston Scientific, and there are different vendors. But if it catches the arrhythmia, then good and well, we will be able to have the diagnosis. We can go ahead with treatment strategies. If those monitors don't work after 4 weeks, I didn't put this in my slideshow, but there are longer term monitors that we can put actually under the skin, and we can leave them for up to 3 years. So the point is, there's so many ways of detecting AFib, from just very simple things that you can do as Apple Watch, go all the way up to implantable monitors that we can put inside under the skin, and we can leave them for years. Treatment. Okay, so now I learn about AFib, I know the mechanism, I understand, I know the risks. Okay, stroke, it can cause heart failure. What are the symptoms? How can I diagnose it? Okay, we have a diagnosis of AFib. How do we treat AFib? So the number one thing, as I mentioned, is trying to avoid a stroke in patients with atrial fibrillation. So we tend to put all those patients on blood thinners. And again, the risk varies from one person to another, but being on a pill as a blood thinner to prevent stroke is one of the most important things for AFib patients. As I mentioned, this is a busy slide. I'm not going to go over all the details. The risk of stroke kind of varies from one person to another. Females tend to have higher risk, age of 65 and above. If you've had a heart attack in the past, you have diabetes, you have hypertension, all of that adds. And the more you have, the higher the risk of stroke becomes. Okay, what are the blood thinners that are on the market? You probably see the ads all the time. Warfarin or Coumadin, that's the godfather. It's been around for 50 years, but it requires a lot of checking of how thin our blood is by poking our fingers. It's called INR. And warfarin, over time, kind of started, people started using less and less. Now, the three most common ones on the market are called Eliquis, Xarelto, and Pradaxa. They have similar mechanism of action in a way. Pradaxa is a bit different, but they do the same, and they serve the same purpose of thinning the blood so you don't form blood clots. So number one is stroke prevention, blood thinners. Number two, what do I do about the fast heart rhythm itself? There are two ways of approaching this. One is we leave the two upper chambers quiver, and we give medications to help the guard between the lower chamber and the upper chamber do a better job to prevent this fast heart rate from going down. And this is called rate control strategy. We just control the rate. We ignore the upper chambers completely, make sure that the lower chambers are not beating super fast, and we see how the patients do. This is an older way in a way. This is more of like people used to do this a lot 10 to 20 years ago. But now we have different strategies where so the first one is this green arrow helping this guard. The second one is actually no. We say we want to get rid of the bad guys in the left upper chamber who are actually causing us issues, so we can put the heart back in sync and have the maestro, the sinus node, beat and become the only master in the heart, so the upper two chambers are not quivering and every part of the heart is in sync. The second strategy is called rhythm control strategy. So there are medications to help the guard. That's number one. Number two, rhythm control strategy. And what do we mean by rhythm control strategy? There are medications that we can use to do this job. However, those medications tend to be a little bit more like they have to be prescribed by an electrophysiologist. They need close monitoring, and we usually start those medications in an inpatient setting. The other option to achieve rhythm control strategy is we actually go in, find those bad guys, zap those bad spots, get rid of them. And that's called an ablation procedure. You probably heard the terminology over and over again. Ablations have been around for almost, I'd say, for atrial fibrillation for 25 years. And there are so many things that happened over those 2 decades in terms of technology advancements and how safe those procedures have become. And, to actually, and the technologies and how to improve the outcomes of those procedures. So medications, as we talked, the medications to help the guard and slow the heart rate. You'll hear a lot of those medications: metoprolol, carvedilol, diltiazem, verapamil, digoxin. You will have a friend or a family member who's on one of those medications. And then the other set of medication that helps with keeping the heart in sync, which are those 5 medications. Most of them need close monitoring, make sure that the kidneys are doing okay and the patient is tolerating them well. They're actually efficient and they do a decent job. We tend not to keep the patients on them long term. but they do a decent job. And then the catheter ablation, as we talked. So let's talk a bit about catheter ablation for atrial fibrillation. You know, there's so many people now showing up to our clinic for catheter ablation, and trying to, you know, pretty much go zap. They would ask me like, hey, why didn't you go zap those bad guys, bad spots, fix my heart, bring it back to rhythm, and move on. So catheter ablation in the past, like any technology, when it started 25 years ago for atrial fibrillation or so, it was more of a long procedure, 6-7 hours. The technology wasn't there yet, so the outcomes were kind of not the best. But as technology advanced and the outcomes have been better, and the research studies showed that patients have improved a lot when it came to symptoms and quality of life, the American Heart Association, American College of Cardiology, and the Heart Rhythm Society recommended that this would be what we call a class 1, like the first go-to for a specific set of patients. So if a patient is still in a way early on, in and out, paroxysmal, as we mentioned earlier, and they are having symptoms, it really makes a big difference and improves the quality of life. If a patient is having heart failure, where his heart muscles is weak and he's having AFib, that's also a very strong indication to go ahead and try to do those procedures. And then even for patients who are in persistent or more of a permanent, they're not tolerating medications well, and they are not, we're not able to bring them back to sinus. We can try catheter ablation on those patients. I had a patient who showed up last week. She's been in AFib quite some time, almost 6 years or 5 years. And she was asking for a catheter ablation to be done now. Are the success rates are as good as someone who's been in AFib for a few weeks? Hard to say, probably not, but it's worthwhile trying because she is not tolerating other medications. So what do we do when we take a patient to do a catheter ablation? We go inside the heart. This is actually a real case where we put our catheters inside that left chamber. We have biomedical engineers sitting outside. Those catheters have sensors, and we go inside, move the catheters inside, find the bad spots. The color codes, each color code has a meaning for us and indicates something. We do a lot of those mapping catheters with. We're monitoring heart rhythm closely. It's usually done under general anesthesia. We can do it under half moderate sedation, where patients are half awake, but most likely we'll do them under general anesthesia, and we find those bad spots, and then we go ahead and ablate and start getting rid of those. Technology, again, has changed. Years ago, we used to go freeze the tissue to a very low temperature, and this is how would we kill the cells. And then it was what we called cryotherapy. And then after some time, we radio frequency therapy, which was used for different kind of ablations, was used for atrial fibrillation. It's more of like holding a paintbrush, and you do a point by point, and you try to burn those spots. We did this for many years. Outcomes were okay, but the problem with heat energy is it would cause damage to some surrounding structures. So we have to be very, very careful, because the heart is surrounded by the food pipe behind. There are nerves that are moving, that are crossing different walls of the heart and chamber. So we have to be very cautious when we're using radio frequency to zap those spots. Now, what has changed remarkably in the ablation world over the past 2 years was and you will hear this also, is called PFA. So it's a different way of killing the tissue and zapping those spots, pretty much to make it very simple. Magnetic field at a very high frequency that creates holes inside on the wall of the cell and causes the cell to slowly die. It's safer, does not damage the surrounding tissues, and we don't have long-term data yet, but what we've had from clinical trials and research studies and what we've been doing over the past 2 years is very promising that the outcomes will be pretty good. So we put our catheters on the left side of the heart after we do the mapping, as I showed you in the last video, and then we advance those catheters to the bad spots. We kind of know where most of the AFib annoying parts or spots are, and that's when we go ahead and zap those spots. So it has become safer, it has become efficient, and it really, I've seen it improve a lot of symptoms and help with quality of life. Again, now ablation procedure, just a few things to know about. It has become almost a same-day procedure. So you come and you get the procedure done. After the procedure, you'll be resting in bed for 4 or 5 hours, and then you will go home. You will be on blood thinners after. I mean, we agreed that you're on blood thinners before, but very important to stress on the fact that you will be on blood thinners for at least 4 weeks afterwards, religiously. And then, as we mentioned, it alleviates symptoms and help the patients have a better quality of life. Now, what is Watchman? Because there are so many ads on TV. I'll be just in a family gathering or an outing, and I'll be asked about the Watchman procedure. So we had mentioned that patients with AFib at a higher risk of stroke. They form blood clots, they have stroke, and the treatment is pretty much putting them on blood thinners to make sure that they don't develop strokes. What if I put a patient on a blood thinner and for any reason this patient starts bleeding? So some patients will have bleeding in their food pipe, gastrointestinal bleeding. Some patients have bleeding in the urine. Some are going for procedures, biopsies and stuff, and they bleed after those procedures. Or even frail patients who tend to fall a lot, hit their head. While you're on blood thinner, the risk of having bleeding that's very life-threatening and dangerous become much higher. So that's when Boston Scientific, it's a famous company, had bought a startup many years ago, and this procedure, this device comes into play. It's called the Watchman Flex Pro, and the whole idea of this, in the left side of the heart, where clot tends to form, we go put the Watchman device in this pouch. It's a pouch, and then make sure that this device clogs the pouch, come out. After some time, our body forms a layer of tissue on the surface of that device, and then the risk of clot formation becomes dramatically lower, if not gone completely, and then patients will be taken off blood thinners. So simple, and this pouch where blood clots form is like anything in our body. It has different shapes, different sizes, and we call it the appendage. So, we go in, make sure that we have all the imaging, the sizing of that appendage. Some patients are a little unfortunate to not qualify for it, but for the most part, there are different sizes of that device. We get the images, send them to the company, and then we go and with ultrasound guidance and under X-ray, we go deploy the device at the opening of that pouch so we can clog it. Very important to make sure that we keep the patients on blood thinners for at least 3 months afterwards until the surface of that device gets completely sealed, as this video is showing by time. And that's when we go back with ultrasound, make sure everything is clogged and sealed, and we take the patients off blood thinners. So I wanted to show you here. See this video. If you notice here, this is a layer of tissue that had formed over the surface of the device. And that's when we say, okay, you're now safe. Do not take blood thinners. Move on with your life. I mean, we tend to keep them on baby aspirin afterwards, but that's all. Coming to the last few things, and we're almost done here, the lifestyle modification. What can I do if I'm a patient who has AFib to help reduce the burden of AFib and make sure that my heart is not suffering? I cannot stress enough on the importance of exercise. I know we'll talk about this, but weight loss is extremely important. It helps a lot. A lot of studies show that with weight loss, the burden is reduced and you're saving yourself a lot of hassle. The usual that any heart doctor would tell you, as the less processed food, more fresh vegetables, fruits, lean stuff that's less fatty, less fried will help a lot. As we mentioned, we talked about sleep apnea. Using your CPAP is very important. And it really doesn't just help the breathing overnight in your lungs. It has great, effects on the heart. Drinking. I've had someone who told me occasionally drinking over the weekends turned out to be a bottle of vodka every Saturday. So be reasonable. 1 to 2 glasses of wine every, couple nights with dinner is fine. But when we're doing, beers, a lot of beers and a lot of hard liquor, that's when we start running into trouble. Smoking, of course, diabetes and hypertension should be strictly managed. You know, I get patients saying, "Oh, I'm diabetic. When was the last time you checked on your hemoglobin A1C?" Which is, and you know, it gives us an idea about how controlled the diabetes is. And they would tell me, "Oh, I haven't checked in a year or a year and a half." It's important to keep an eye on those things because that also affects and reduces, you know, it helps at least improve the outcomes when we're trying to manage AFib. Exercise. The one thing I've seen commonly over and over and over again, and anyone who's above the age of 90 doing well, is being active. And I stress on this all the time. Stay active, and staying active varies from one person to another. You don't have to be weightlifting every day, but stay active. Get out of the couch and get out and do some brisk walking. You know, I had patients who, you know, have target number of steps for themselves every day. I want to do 10,000 steps. I want to do 8,000 steps. Walking, as I mentioned, weight training, cycling, swimming, running, even yoga has some positive effects and impact. So very important, exercising. It's very beneficial. Dementia, respiratory, and of course all the cardiovascular disease. So very important. The one thing I want to say at the end is if the whole point of managing AFib is to reduce the burden or the amount of time our heart is in an abnormal heart rhythm. If someone is in AFib, you know, 6 hours a day and we're able to reduce it to 1 hour, it's a success. If someone is in AFib 24 hours a day and we reduce it to 2 hours, it's a success. If someone is in AFib 7 days a week and we reduce it to 2 days a week, it's a success. So every heart is different, every patient is different, everyone's priorities are different, but we try to tailor our management strategies to those patients to make the best out of it. And just again, don't if you're diagnosed with AFib or you're thinking about it, don't make it take away your joy. Stay active. I've had patients with AFib for you know, 30, 40 years, and they're doing great and they're happy. And that would be it. I'll be happy to answer any questions.
Thank you so much. We do have a bunch of questions. That was fabulous. You took a very complex topic and made it a lot more easy to understand. One of the questions that kind of ran through a number of people is the difference between AFib, fluttering, PVCs, and a murmur. You know, what's going on with all of those? Are they the same, or what's the difference?
Okay, this is okay. I would go back to the very, very first, you know, picture I had about the heart. Okay, this one can even suffice here. So we said that AFib is usually abnormal heartbeats, many spots in the left upper chamber that are, you know, beating and sending messages. Atrial flutter is different. Think about atrial flutter as a circle. So the message comes down from the normal master, and it gets, instead of going down the wires the normal way, it gets stuck into a circle. So it keeps, you know, revolving in a circle. And every time it keeps turning at a very fast heart rate, the heart starts squeezing in the upper chamber and the lower chamber too. So it causes an arrhythmia, but it's not super chaotic like AFib. Atrial flutter has a little bit of an organized rhythm in it. It's just so fast because there is one circuit that's causing the problem. Now, atrial flutters, you use the same mapping, you use mapping systems, try to find where the abnormal circuit is, and once you zap one spot, you usually stop the flutter circuit. So that's flutter and fib. We call them, you know, siblings because it's the same spectrum. You know, we also apply the same, you know, blood thinner strategy, and we try to reduce the risk of strokes. Of course, way more dangerous when it's on the left side as opposed to the right side. So I just want you to understand one important thing, that abnormal heart rhythm coming from the right side of the heart can cause clots to happen, but this right side pushes the blood to the lungs. So if any clot is going to form, it's going to go to the lungs. I'm not saying it's a good thing, but it's at least not as, you know, super serious and life-threatening as it could be, but it's not as sending the blood clots from the left side to the brain. So flutter and fib usually keep patients on blood thinners. Fib is flutters, especially on the right side. We can take care of it and by burning a few spots and doing an ablation in a few spots. Fib is a little bit more complicated in a way, and it tends to be a longer course. So that's fib and flutter. Now, PVCs, the abbreviation. So we said the two upper chambers are called atria. The two lower chambers are called ventricles. Every now and then, you get just one spot that sends an abnormal extra message for the heart to squeeze and beat, and what we call premature complex. If this comes from the upper chamber, it's called premature atrial complex. If it comes from the lower chamber, we call it premature ventricular complex, a PVC. So a PVC is not a continuous abnormal heart rhythm. It's an extra beat that can come every now and then from a certain spot of the heart, and it goes away. Now, I see patients with an abnormal, the medical terminology is ectopic. So I see patients with a PVC, but the burden is less than 1% of their total heartbeats. We don't really do much about it. If the burden is 20%, is 15%, that's when we have to start managing those either with medications or we go inside the heart, find where the spot is, and we zap it and we get rid of it. So atrial fibrillation, atrial flutter they tend to be longer. And patients can feel them if the heart is going too fast. An ectopic complex or an extra beat coming from the lower chamber, PVC, or coming from the upper chamber tends not to cause, they wouldn't cause as much symptoms as the other ones, but if the burden is high, then we go after them. Now, murmur is a completely different scenario. Murmur is, so we're the electricians. There are other cardiologists that work with the blood flows, but if on this diagram, on the inside, blood flows from one room to another through a door. It's a door that opens and closes. It's a valve. If this valve is leaky or if the valve is tight, as the blood is flowing, it causes turbulence, and that turbulence can cause a noise, and the noise is a murmur. So a murmur is something that we hear when there's turbulence in the blood flow crossing narrow or super wide areas. Think about it as holding a water hose and trying to press on the tip of that water hose. The sound that can happen because of the water going under pressure is what murmur is. So murmur is not an electrical issue. Murmur is blood flowing from one room to another that had to do with valve abnormalities.
We are at time, but I would like to try and ask you one more question. And then if there's some other questions in the chat that are more specifically towards medications, and that some of them are more geared towards their own primary or their own doctor and their insurance company, but something that's kind of thread through them is, if I'm going to catch this, you talked about taking your own pulses. Is this something that my general practitioner, when I go for my primary care, is going to do? And besides just the diet and exercise, is there anything that we really need to make sure that we're doing to prevent this? Is it preventable, or are we just trying to do things to kind of control that? So those are kind of threads that are through a number of the questions.
Right. So two things, right? Some patients will get AFib even if they're doing everything right? But most of the patients will have a role into preventing it. I mean, it comes down to the usual day-to-day things that you will hear on TV. If you're taking care of your activity level, if you're eating clean, if you're staying away from a lot of drinking and smoking, and if you have high blood pressure, you're actually taking your medications on time, checking your blood pressure at home every now and then, making sure your blood pressure is controlled, your diabetes is not out of control. Yes, you're saving yourself a lot of hassle. You probably will reduce the chances of you getting AFib, and even if you get it, you will not have a high burden of AFib, and it will be easier to control it. So the answer, I can't give you a black and white answer, but we do our part. And if our bodies are not responding well, then we do something different. But I wouldn't just stay on my comorbidities and not keep a close eye on them and just let things be. And I say it's going to happen anyways. It's more of a joint effort where we do our part. The physician or a cardiac electrophysiologist will do his part. And I have a lot of success stories where patients come, we get things and the risk factors under control, and then we treat the condition with ablation or a procedure, and then we do some lifestyle modifications, and they stay AFib free, or at least with a very low burden for many years, and they do very well. So that's important to note. Now, the first part of the question, Jen Marie, is pretty much, how to check it. Checking pulses from home. You can do it with your own hands. Use an Apple Watch if you're thinking you're having symptoms. Buy the Cardia app off Amazon and see if you can put your fingers on those electrodes and kind of diagnose it or catch it when it's happening. And if this is all not taken care, not catching it, and you're still having symptoms, just come see an electrophysiologist, go see a cardiologist somewhere, or even a primary care physician if they have the capacity to get a monitor on you and put a monitor on for 2 weeks, 3 weeks, 4 weeks. We should be able to catch it.
Then that was my next question. So they can come straight to a cardiologist, cardiac physiologist, if their insurance allows that, or should they be coming through a primary care to get a referral?
No, most of the insurances will be okay with them just scheduling an appointment to come to us directly. Most, I'd say 90% of those will come to us. Now, I want people to be aware that a cardiologist is different than a cardiac electrophysiologist. A cardiologist will treat everything in the heart. Cardiac electrophysiologists deal more specifically with rhythm abnormalities in terms of the medications that we start for AFib and the procedures and all of this. So our structure in our clinic, we get patients directly to us. We get patients from cardiologists if they have rhythm issues, and we get patients from primary care physicians, less commonly though, but we get those. So at this point, we try to help everyone. And I just saw a young lady, if she really didn't see any providers before and she's having a lot of palpitations or not able to catch it on, with pulse checks and EKGs. So I just put a 4-week monitor on her. The good thing too is us as electrophysiologists, we have live access to the portal that has the monitor. So if I have 40 patients on with the monitors on, I can log in almost every day and take a look at their heart rhythms. Okay, fine. If there is an alarm or something that that's unusual, we actually get to see it on that portal, and I'll be told, okay, patient X, Y, and Z had a 2-minute episode of abnormal heart rhythm. I can open it and look at the strip. So we have live access to those as well. There are different ways of doing it, but most of the insurance companies would be okay sending us those patients.
Excellent. Well, I want to thank you so much. And I recommend everybody, if you're not seeing your primary care, make sure you're talking to them as your first step in defense. If you are finding that you're having more issues going on and you need a specialist, we've got a great one here for you to kind of look into. We appreciate you all being here. And Dr. Khalil, thank you so much, because this was an incredible presentation. And I know a lot of people are coming back to watch it. It is recorded and it will be on the BayCare Present site in about 2 weeks. So thank you everyone for being here.
I appreciate you, Jen-Marie. Thank you so much. And I'd be happy to help when needed. Have a wonderful day.
Thank you.